As we all know, what is palliative care? Palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with life threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Nurses play a very important key role in palliative care. To know about this substratum of palliative care, we have three roses here to add taste, color, and flavor towards our topic of today's webinar. A perfect combination of expert professionals to talk on three aspects of palliative care. One is the overview of palliative care. The second aspect is overview of end life of life care. And third one is nurses' role in palliative care. With this, I would like to introduce the first speaker, Professor Angel David. Madam has completed her UG and PG from Christian Medical College, Vellore, Tamil Nadu in the year 2007. Additionally, Madam has completed MPhil Psychology, postgraduate diploma in guidance and counseling, postgraduate diploma in hospital management, short course on fundamentals and biostatistics and SPSS at Christian Medical College, Vellore, certificate course in essentials of palliative care by Indian Association of Palliative Care at Jeevodaya Hospice, course on research methodology at Department of Continuum Nursing Education, College of Nursing, CMC, Vellore. Currently, Madam is pursuing her PhD nursing from the Tamil Nadu Dr. MGR Medical University, Chennai. Madam has a vast experience from the post of staff nurse to the professor level. To add to her credentials, Madam has received many awards and prizes during her postgraduate as best clinical nurse and then best student during her final year of clinical experience, first prize in poster presentations at national and international conferences, and Madam has published and presented n number of papers in national and international conferences. With this, I request Professor Angel David to talk on overview of palliative care. Over to you, Dr. Angel David.
Good morning to you all, and thanks a lot, Dr. Sharmila, for the introduction that you have given and for the kind words spoken on behalf of me. I owe it all to God. I want to thank God for this opportunity that you have given for me to present this August gathering of professionals. Okay, so I'm so glad that we are all gathered here with the interest to know much about palliative care. I will not assume that you know nothing about palliative care. I am sure you have already done more reading than even me about palliative care, and you must have come well equipped for this. So it's more like a small talk. So to talk about palliative care and to give an overview, I would start from what would be the focus of palliative care. Okay, so now the focus of palliative care is going to be completely about palliation. So when we say what is palliation, it is to palliate, or it has the word palliative care has come up from Latin words, which means to, if I were to use the Latin words, they are palliate, palliare, or pallium, which means to cloak or to mask. Now, with this COVID-19 situation, all of us are well aware of this masking. Okay. Now, in palliation, what are we trying to mask? Okay. So here, basically, we are trying to mask the symptoms of a disease. Okay. How, in what way are we going to mask the symptoms? We are basically trying to make the symptoms less severe or get it decreased and alleviated. So it's all about getting the symptoms of the disease under control, because of the fact that we are unable to do anything about the disease itself, or everything that has to be done for the management of disease has been done. And so now we have reached an impasse and wondering what else to do, what can be done, or where to take it from here. Then at that point, we talk about management of the symptoms. So palliative care is all about providing supportive care. Now, if you were to ask me, what are the symptoms that we are going to manage in palliative care, then I would have to go to give you a brief idea about the beginning of palliative care. Now, we always give the credit of founding palliative care to Dr. Dame Cecily Saunders. Okay, so this particular person was basically a nurse. I'm so happy, proud of the fact that nurses think a lot. Nurses are so observant that they could always, try to find a solution to the problem. So she was basically a nurse who later, because of her interest in social work, also became a medical social worker. And because of the opportunities available in her country, she later also studied to become a physician. So in this process, like when she was about 30 years of age, she falls in love with a person who was a Jewish refugee. So she begins to take care of this patient. Okay, unfortunately, basically, initially he was just a patient, but she falls in love with him. And as she provides care for this patient, and this particular person was a refugee and he had cancer. So she provides care with utmost sensitivity of heart that this man, when he died, okay, he bequeathed all that he had to her, in the sense he had property or money worth of 500 pounds. This was way back in 1850s, okay, 1848 onwards, she begins to take care, and then around 2 to 3 years, and then he dies. Okay, so it was in the 1850s, and at that point, 500 pounds was a big amount of money. And he said, let this be a window to your home. And from there, she starts off a hospice. So this is the place where she begins to think that she is going to care for the cancer patients, and especially those cancer patients who did not have any hope, or they were like the dying cancer patients. So it is at this point she comes in, and then she starts off. So no wonder that if in today's knowledge or whatever it is, if today we are going to ask someone what is all about palliative care, immediately people would say, oh, palliative care is all about cancer. Palliative care is all about caring for the dying. So, yes, it does owe to its beginning. And then to continue with the story, Dame Cecily Saunders in the year 1967 establishes the Saint Christopher's Hospice. Okay, by this time she has collected a lot of money and she starts off this hospice. And before she even could start this, some 7 years back, in the year 1960, she begins to take care of another patient, and he was like quite sick for a period of 7 years, and she was really taking care of him. And we have literature to say that she again fell in love with this particular patient also. So here she takes care of this patient, and then in a very sensitive manner, so much so she knows all about what this person is going through in his stages of dying. And then she even says that, as the body becomes weaker, so the spirit becomes stronger. So this was what she understood when that person died in the year 1960. Okay, so this patient dies in the year 1960, and 7 years later, she starts this hospital. Okay, so uh, with her experience with the care of the dying and what happens what happened to her as she also went through this grieving process made her a great person who could really contribute much palliative care. And today, palliative care is more well developed and it is so modernized. In the year 1987, palliative care becomes a medical subspecialty. So this was something like a big improvement given for palliative care. And with this came improvements in the care of patients. Research started in a very scholastic manner, in a very formal manner. Professional education and training were provided for people who or professionals who wanted to specialize in palliative care also. But once it became a medical subspecialty and doctors and nurses were trained in it and they started providing care, then the public also began to gain an understanding about what this palliative care was all about. Of course, even in 1987, it was more restricted to the care of cancer patients and AIDS patients and some of the neurological patients. And later, uh, from the understanding of the public, because now public were getting more aware of it, then politicians also started to take note of this and began to think about what needs to be done in terms of policy change or provision of even painkillers and opioid analgesics for this palliative care. And so many people started looking into what can be done for this particular medical subspecialty and what can be done for the patients in their loneliest time on their life journey. Now, today, as of today, if we are going to look into what palliative care comprises, it basically does involve the terminal care of patients. It takes care of patients of any type of cancer and end-stage renal disease. It takes care of patients with very chronic conditions like COPD, asthma, and it also takes care of long-term care. Okay, the short-term integrated palliative care uh, model. So this is one new model that they had developed, and this has helped in the long-term care of neurological conditions. So people with multiple sclerosis or even motor neuron diseases, all these patients again fall into the umbrella of palliative care. Now, in today's pandemic situation, can you believe hospices extend palliative care to COVID-19 patients also? So we basically from palliative care try to provide the needs of the society. And then, of course, it does have some components of care which should be, of course, be looked into. So now looking at the components of care, you know, uh, it starts with symptom control, as I told you earlier, and then it talks about terminal care. Okay, so from the time the patient gets admitted in the palliative care, okay, there is a place now where there is a continuity of care. Before, when the hospitals let go of patients in the sense saying, yes, this is all that we could do for you, and now you will just have to manage your problems. So when that kind of an impasse was reached, and then there was a question about the continuity of care, then we have this palliative care to provide the continuity of care. It helps in the rehabilitation of the patients there, and it also provides for terminal care. And this terminal care is something that is very, very important. As I told you, this is the point where the person takes a loneliest journey. Okay, the feelings, the thoughts, the emotions that the person goes through will be very intense and will be very different from the point of view of others. So it is very important to have effective communication, which is again an essential component of palliative care. And and then we should not forget the patient's family members. The family members definitely are in a state of turmoil, a lot of emotions and helplessness as to what can be done. Oh, we cannot do the best. They have this feeling that they cannot do the best for their patients. So we need to again involve in effective communication and involve in providing education for both the patient and the family members, and then support in the bereavement, prepare the family to face this bereavement and support them through the grieving process itself. And then with this, palliative care doesn't end, because if I stop with this, it is about the services to the patient alone. And of course, the medical professionals or the healthcare professionals have to receive their own education and training, which is again provided from the field of palliative care. And it opens its vistas of research for everyone to who is interested to be involved or who has ideas for improvement of the welfare of the patient. Then again, there are areas of research ultimately contributing to the patient and to the society, to the nation, and to the worldwide care of our fellow beings. So these are the components of essential or the essential components of palliative care. Now, I would also go on to talk about the dimensions of palliative care. Now, palliative care, being a part of healthcare, is not very far from providing holistic care. Okay, so we do provide holistic care for the patients in the sense their physical care is taken care of, their medical care, the nursing care is taken care of. So again, they are all coming under the physical care. And next thing is the emotional care. So much of it lies in effective communication, the emotional care, and then not to miss out on the mental or the psychological care that is given for them, psychological support. And then, very important, the spiritual care. The all of us now know the difference between religiosity and spiritual care. Okay, so it is when we talk about spiritual care, it does not talk about embracing a particular religion. It talks about how much the person finds purpose and meaning in life. So it is not that a person should find a purpose and meaning in life only when we are well, but even when we are not well, then at that point to understand the purpose and the meaning in life, meaning of that suffering itself, this should be talked about. And for that, we need to have a profound understanding about what are all these dimensions and what are the various aspects that are lying in here. And then we our interaction, because nobody is born with that ability to give care. We develop these skills and we develop it more as and when we interact more with patients. Sitting in the colleges, sitting behind books and desks will not help us to get the knowledge. I cannot, I can probably talk from the textbook if I were to only look into the textbook, but it is the experience with our patients that will give us a profound understanding of what it is to care. That is what made a difference in the life of Dr. Dame Cecily Saunders. Her interaction with patients. Actually, I'm looking forward to listening to Dr. Deva Kirubai, because she has such a palliative care. I'm looking forward to listen to her experience, because it is these experiences that really teach us a lot. And from this, okay, so talking about that spiritual care, when you try to help them find that meaning. So you first of all find meaning and purpose, and you help the other person find out that meaning and purpose even during this time of their suffering. And ultimately, telling, achieving the goal or the objective of palliative care, which is to improve the quality of life of the patients. Okay, so all these things are put into. For one thing, we want to improve the quality of life of these patients, not just the patients alone. We also want to reduce the caregiver burden for those family members who are so involved in the care of these patients. And then I would also like to, you know, uh, uh, introduce this thing that palliative care is not something very, of course, it is a specialty, but it is not something too specialized that you have to definitely get a post graduation or a master's in palliative care to provide that palliative care. Okay, of course, it does have specialized knowledge, but you know what? Among all these patients who need care, it is only 10% of those patients who will need this kind of specialized palliative care. So there are this 90% of patients who do not need this specialized palliative care. So that is the need why we are having webinars like this, to interest each and every one of you who come across to this kind of webinars or conferences, to have this idea that though you are far from palliative care, you do have a role in palliative care, because palliative care begins from the time the patient comes to us in the hospital. You understand? When they come to the hospital, don't they have this needs of needing to have a symptom control? Don't they have this need of having a continuity in care? And don't we have the need for being involved in effective communication and support them in every phase of their life? So if it is so, then we need to know something which is a little more in details about this palliative care. We should know a little more in depth to give that kind of a continuity care or palliative care right when our patients are in the hospital. This will reduce the burden of the specialists in the palliative care, who can concentrate on giving care for those patients who really need the care. And now, looking into what would comprise the palliative care team, of course, there are a lot of people involved in this palliative care team. So if we look into the various dimensions that we are going to give care, then we can easily remember the members of the palliative care. So we physically look into the medical care. So we need to have a physician. It is not important that the person should have trained in palliative care. Yes, it is. It is so important to have such specialized or personnel or such specialists in a tertiary care center. But at primary healthcare center, at even a secondary healthcare center, we do not need to have such palliative care specialists or palliative doctors to look after patients. Any doctor with an interest, who has a heart to care for patients with palliative, with the palliation of their symptoms, can start it off right where they are. So it involves doctors, it involves nurses, definitely, and then so we look into that physical and the medical care. And I talked about nursing care, so nurses are generally there. So we can also have other kinds of nursing personnel who will provide the hygienic care, and to provide the basic routine activities, so that nurses can spend more time communicating with the patients and looking into the psychological needs. Talking about psychological needs, we should definitely have a psychologist there, a psychologist who can work as a counselor. This person would do counseling not just for the patients, but also for the family members. So a counselor is needed. And then for providing various supportive therapy, because we have patients who will be on long-term care. We will have patients who would have who would be probably transferred here to reduce the hospital stay, basically talking about surgical patients. And then when we talk about these kind of patients, then then we need then we need to provide the supportive care, provide uh, the physiotherapy services and any other complementary medical therapies like massaging therapy and all those things. So we need to have such kind of therapists. If we have them all, it is really good because we can then provide care for a wide range of patients. Then we talked about spiritual care, though it's not connected with religion, then we have chaplains who are trained in providing this kind of a spiritual care for patients, who help patients find meaning in life. So we can, as nurses, we always have, a lot of work. We always put our fingers at everything. We of course, sometimes people even mock, we are jack of all trades, you see. So so like that, we can we can
palliative care பத்தி. அங்க வந்து நின்னு இன்னைக்கு மீட்டிங் இது மாதிரி.
May I please request the participants to mute your mic because it's sort of distracting. Yeah, sorry. Okay, so we have to have the chaplains, and then we need to have social workers because these are people who will help us to get the background of the patient. Okay, so they will again spend time with the patients collecting various other details so that we are kept abreast about whatever is the background of the patient, and so that we shall be really be understanding as to what kind of care can be reached and provided and reached, and so that our patients can be reached unto. So today, palliative care is not just restricted in the hospices. Hospitals should start providing palliative care. Then apart from this, palliative care can be provided even at the patient's home. So this is the home health services that can also be provided from palliative care. This is just reaching out a hand to reach out the patients and providing care for them right in their home. So this can be even considered as a community-based palliative care. So palliative care centers run OPD services, they run home health services where a small team consisting of a doctor, a nurse, a psychologist, a social worker, and sometimes even a chaplain. Just these five, making a small team, they go to the patient's home, visiting them right in their home. They check the drugs that have been given to the patient while probably when he had come to the OPD, and they check about the compliance of the patient, look into the family background, look into the family environment, and then they provide necessary health teaching, and thus they reach out to the family members. So this is actually an interesting field where nurses can really reach out, and this has both community as well as the medical surgical part of it. And of course, when you have children receiving terminal care, you have the pediatric services. It is basically all specialty in one. Okay, so such is the field of palliative care, and this is something that I would basically encourage each of us to take interest in at least having a small certificate course, which is like a 3 months course, where we will gain knowledge, and then we are also given some exercises or assignments where we will have a patient to patient interaction to do those assignments. So I am here also to encourage you to take up some short course in palliative care, so that, see, without us learning, we cannot really put certain things into practice. Most of us learn only before exams. Coming and sitting here, we may try to do it for probably gaining some continuing nursing education points so that we can have our registration active. we may have multiple reasons why we are attending. So if we take a course, then it means you mean business. You are interested in care. You are interested in doing something or contributing for the welfare of the patients. So I think I have sort of provided a sort of an overview. I'm sure I would have left certain lacunae. Of course, while I was discussing with Selma, who's also the resource person here, she even told me to give a list of the palliative care centers. Then I thought I will not give you this because when you Google it, you can find it. And this is exactly what I would have done also. Google and bring it. And then I was able to mention just a few centers and leave out some of the other centers. So for that sake, for preventing this kind of discrepancy, I would leave it to you. So based on, I'm sure that every state does have its own palliative care. Talking about Bengaluru, I took a little bit of training in one of their hospice, Karunashriya Hospice. So I'm especially mentioning this because I'm assuming that most of you participants are probably based in Karnataka or in Bengaluru. Okay, so that is about the various centers of palliative care. And so now probably I will just tell a little about what should you have in a palliative care center, and then probably give the time over to the others because we do not have much time also. Yes, so before I would close, if I were to run a palliative care center, say for example, for a long time, I know some of my very close friends will know that if they asked me what was my dream, or if they asked me what are you going to do, I would always say, I have this dream of having my own palliative care center. Actually, this coming of pandemic has really sort of near demolished that dream. I'm like wondering, oh my, what am I going to do? But I do not know what is God's plan for me. But then I always used to think about having my own palliative care center. What would I be focusing on? Definitely on these dimensions. So I will have the necessary, not a big team, because I'm not interested in having a big center. Something small where you provide meaningful care for patients who are in need, and not just meaningful, an affordable care. And then also talking about, apart from all these things, also talking about diet, because one of my whole interest in my research study is the importance of a complete plant-based diet in care of cancer patients, especially in their terminal care. So I'm not going into depths of it because that doesn't come into this, but I'm just saying. So I would also focus on the diet that should be probably having a, not probably, it does have an impact on the healing or even on the improvement of care that we can show in the patients. So having said all these things, I would, I have forgotten. It's not that I have forgotten. I purposely missed out and on not telling the definition of palliative care. Yes, so this is because I wanted to end with what this palliative care is all about. Okay, this palliative, yeah, before I mention that, I'm sorry, I missed out on the principles of palliative care. I'll tell this and then we will go on to the definition of palliative care. Okay, talking about principles of palliative care, because this is something very, very important and I should not miss out on this. Number one, it affirms life and regards dying as a normal process. So life and death are normal processes. So this is something that we should accept and then deal with it. It neither, palliative care neither hastens nor postpones death. It's a normal process. It occurs at the time it occurs. And so we do not do anything about it. We are present there with the patient in that loneliest hours. Okay, and we also allow the family members to be with them there if they are with us in the palliative care center or in the hospice. If not, we or we go to their homes and we, if possible, can be present there. Next, it integrates the psychological and spiritual aspects of care. Okay, so it is very important. The integration part is very important. So that is something that we should not miss out, because talking about hospital, we do an integration of, the medical services, nursing services, diagnostic services, and all the other supportive services. And of course, a lot of other hospitals do look into the spiritual care, and they do look into even the psychological care of patients. But then in this, when our one of when we look into the major dimensions like the psychological and emotional and and the spiritual part, we definitely need to integrate these aspects of care. And then we provide a support system to help patients live as actively as possible until death. That is what we mean by improving the quality of life. And we offer a support system to help patients' families cope during the patient's illness and in their own bereavement. So these are the principles. I know I did not state them like that in my speech, though I had sort of covered everything. And now coming back, when you leave this place, now what is that kind of a thought that you will have to that you will carry forward? Okay, so this is one place where we look into freedom from pain. Okay, so we talked about symptom control, and we talked about um, management of all the symptoms, and then we also talked about various dimensions of care. Okay, so I'm really sorry, I'm just looking for my slide. Yes. It is palliative care is the care of patients with active, progressive, advanced disease. So what do you mean by that? It involves patients with active disease. It involves patients with progressive disease. It involves patients with advanced disease. As I said earlier, I want to reiterate the point that we start giving care right from the time of a patient's diagnosis of any illness. Okay, so starting from that diagnosis, we go on until we know the prognosis. Okay, the definition continues like where the prognosis is short and the focus of care is the quality of life. Okay, so when we come to know that the prognosis is poor or is very short, that is the time we really take the yoke upon us and we really look into, because that is the time when most of them involved in the care will lose their hands, will take off their hands. But we step in there and we try to increase their quality of life. Remember, friends, quality of life is the basic human right. It is not a luxury for a few. It is a basic human right, which means every individual is supposed to receive it. And as healthcare providers, we are in a state where we should provide that quality of life. I hope now I have done some bit of justice to give an overview of what this palliative care is all about. And then I really didn't want to tax you with so many terminologies and stuff like that. Now we shall continue with the rest of the webinar to know in depth about what we still need to know before we leave this place. Yeah, thank you so much for your patient listening, and over to Dr. Sharmila.
Thank you, Professor David, Professor Angel David, for highlighting with us on the overview of palliative care. It was a wonderful talk, and I hope the participants would have understood what is a palliative care by now. And at this juncture, I also would request the participants, if you have any queries or any questions, you can post your questions in the chat box, so that we will have a discussion at the end of the webinar, after the three speakers have completed. And also I request, there will be a feedback form which will be posted at the end, so that you can fill it up to get your e-certificate. Meanwhile, once again I repeat, if you have any questions to be posted, or if you have any doubts, you can post in the chat box, so that we'll have a discussion at the end of the session. Once again, I take this opportunity to thank Professor Ainsley David for this wonderful session. Now, I would request to discuss, to have we will have a next speaker to talk on the overview of end of life care by Professor Dr. Devakribai. To talk or to tell about Dr. Devik Ribai, Madam has completed her undergraduate and postgraduate in medical surgical nursing from Christian Medical College, Vellore, Tamil Nadu in 2002. Madam has additionally completed a certificate course in Essentials in Palliative Care under Indian Association of Palliative Care in 2011, short training course on counseling psychology. Madam is a member of Trained Nurses Association of India and Christian Medical Association of India. Madam has vast experience from the post of staff nurse to the professor level. Madam has organized and attended n number of workshops and conferences, and also presented her papers and presented. Madam was a resource person for n number of conferences and workshops, and also she has published many papers to add to her credentials. And to add to her to add feather to her cap, Madam has got a General Proficiency Award for all the 4 years, first rank in clinical practice, and first rank in clinical practice in the second year, fourth year of all the 4 years. Then I think there are many number of ranks and awards which has to be mentioned. I think this will be no, I have to take much of time to tell about this. Madam is a gold medalist for the best outgoing student in the BSc Nursing to highlight. And also, Madam has secured many same has during her post graduation also as best clinical nurse and also gold medalist. And right now, Madam is working as a professor and head of the Department of Fundamental Nursing and Medical Surgical Nursing at Sacred Heart College of Nursing, Madurai. With this, over to you, Dr. Devakribai, to talk on overview of end of life care. Welcome you, ma'am.
Thank you, Sharmila, for that nice words that you shared with me. But all this credit, I would like to give it to God. And I'm going on to my topic. And thank you, Angel, for that wonderful presentation where you talked from your heart. Okay. My presentation is going to be on an overview of end of life care. Are you able to hear me?
Yes, ma'am. You can.
Yes,
You can.
yes.
Ma'am.
Okay, thank
You
you.
can see your
Yes.
screen also.
Are you able to see my slides also,
Yes,
right?
yes, ma'am.
Okay.
Yes, ma'am. You can proceed.
At the outset, like I want to thank my Lord for life and all that is in it. Because, again, here we are going to talk about end of life. So I think, every day, every minute, we have to be thankful to Lord for giving us this life. And what I would take at the end of this presentation, if all three of us have inspired someone in this webinar to do their best to provide a wonderful end of life care to the patients. And I think, I would take that as a biggest success. And at the outset, I sincerely dedicate this presentation to my dear patients because in my doctoral thesis was basically on end of life care. And I think, the whole of my nursing career, I have learned how to care for terminally ill patients. But then these patients made a profound effect in my life, especially in terms of providing psychosocial and spiritual care, Most of them are not alive out of 120 patients whom I studied. And I hardly know that there is one patient who's still alive. So I sincerely dedicate this presentation to my dear patients. Um, and this is Dame Cicely Saunders, who Angel was talking about. And one thing that we need to remember here is how people die remains in the memory of those who live on, the family. And that is the reason, like one thing that we have to be really worried about, giving a lot of importance to the quality of death. And you matter because you are you, and you matter to the last moment of your life. And we will do all we can, not only to help you die peacefully, but also to live until you die. And this is a very significant quote of Dame Cicely Saunders, who's the founder of modern hospice movement. I would like to start with the societal attitude of death and dying. If you ask any one of us, okay, we don't want to die. We are, majority of us, we are a death denying society, and we are a death avoidant society, and death is viewed as a failure of healthcare system. We immediately blame that this was not right, and that's the reason, my loved one died. So death is viewed as a failure of healthcare system. And all the innovations and the modernizations has changed death from a sudden event to a long journey. But what we have to really understand is that death is inevitable. All of us, how birth is, so real. So death is, again, these two events are something that is, common to every individual. Now, like I wanted to talk about what is the need for developing end of life care in India. There is, like even in the UG and PG, we talk about death and dying. But to my understanding, I still feel, the due weightage is still not given. And if you see here, why talk about it? We have worldwide 377 adults per 100,000 population. And if you take it in terms of children, it is 63 children under the years of 15 years who need end of life care. And in India, this might be a little, 2 or 3 years old back statistics. There are 1 million new cancer patients every year, and that to 80% are at stage 4 diagnosis. Only 1/3 of patients who need palliative care have cancer, and all the rest 2/3 have non-malignant illnesses. An emerging elderly population is yet another reason why we need to talk about it. And recently, every 5 years, the Economic Intelligence Unit, they report on quality of death. And the last finding was in 2015, which rated India to be at the 67th place out of 80 countries that were rated. This is one reason, why we really need to talk about it. I wanted to talk about the demographic transition that has been happening. According to the Global Atlas of Palliative Care at the End of Life, which released its results in 2014, every year there are 54.6 million who die worldwide. Okay, and non-communicable disease are the ones which is causing around 66% of those deaths. And if you see here, how many people need this end of life by age group? It's around 19 million people needed palliative care, and mostly it is adults who are 60 plus, which constituted 69%. Why am I giving all these statistics? Do we have sound end of life training or, that sensitivity within us? See, this statistics should really sensitize us. How am I dealing with death and dying as a nurse? And if you see here, cardiovascular diseases accounted for 38.47% who needed that end of life. And the next is cancer. But you see here, it's not just cancer. It's any other disease. It could be a rheumatoid arthritis, multiple sclerosis, it could be HIV, it could be diabetes. All these are in need of end of life. And the next thing that I was telling is, even people who die naturally or because of old age, they too need end of life care. So we know that chronically ill aging population is also growing. So along with that, the scope for end of life is also very important. And these are few slides which says how many million are in need of end of life. And if you see this, the green part here is representing India, which is a need of 178 to 272 per 100,000 are in need of end of life care. And still, you know, like we are in generalized provision where we haven't gone into the higher levels, but we are, you know, we are progressing really good in end of life and in palliative care. This is the 2010 index end of life care scenario where, you know, the overall end of life care in India was 40 out of 40 countries. We were, you know, the at the lowest, even trailing behind some of the African countries. But now in the recent 2015, this is how it was rated: palliative and healthcare environment, human resources, affordability of care, quality of care, and how community engagement is promoted. So out of all these criteria, out of 80 countries, we have scored the 67th place. But to add, if you see the quality of death index top 5 countries, it is, you know, almost the European countries are really doing well. The UK, Australia, New Zealand, Ireland, and Belgium. Coming from the clinical imperative, what gave a lot of interest in this end of life care is the famous study in the year 1995, which is called as the support study. So in that study, it is quoted that no discussion of CPR orders. So people were receiving unwanted care, absence of knowledge that patient preferred DNR was in 53%, DNR orders written within 48 hours of death. Families used up all their savings, you know, in treating the patient. The dying was prolonged, and patients who preferred to die at home but died at hospital. So all these findings, okay, gave a lot of push for improving the end of life care. And this is yet another, this is the support study findings. Many patients received unwanted care at the EOL. Clinicians were not aware of patient preferences. Pain was poorly controlled at the EOL, and efforts to enhance communication were futile. So this study revolutionized the quality EOL care. And by any means, if a patient is asking for a physician-assisted suicide, it is a serious distress. And a study quoted, these are, you know, like the beginning studies I'm just quoting here. Severe pain was one reason, and a severe discomfort was at another reason why patient-assisted suicide was requested. And yet another study, what patients and family wanted from the healthcare system. They wanted pain and symptom control. They didn't want life to be prolonged, achieved, to have a sense of control of what is happening around end of life. They wanted to relieve the burdens on family, and they wanted to strengthen the relationships with the loved ones. And what the family caregivers wanted, this is a study of 475 family members. This is after the patient died. They wanted the loved ones' wishes to be honored, to be included in the decision process, support or assistance at home, practical help, personal care needs in terms of bathing, feeding, and toileting, honest information, 24/7 access to care, to be listened to, privacy, to be remembered and contacted after the death. And, you know, like these demographics and the clinical imperatives, you know, has given a lot of discussion. World Health Assembly in the 2014 recommendations has made it mandatory to integrate palliative and end of life care at all levels of health. I'm not talking about only about the tertiary level. Inadequate pain and symptom control and lack of access of essential medications, especially opioids, are, you know, like very similar to torture or cruel, inhuman treatment. Palliative care access is very limited across India, with exception to few places, and access to morphine and other controlled substance for pain and symptom relief extremely limited. But now, after the amendment of Narcotic Drugs and Psychotherapeutic Substances Act in the year 2014, this has been eased to a little extent, and public awareness on the end of life care is non-existent, and the last is healthcare providers are not aware of this. How our patients are dying? 83% of healthy Indian population prefer to die at home, but mostly they die in the hospital. And 78% with advanced illness in the critical care have left against medical advice because there was no end of life care policy due to lack of resources. And all the LAMA patients did not receive any form of symptom relief measures. Patients are dying in the wards and at home with no symptom relief, and significant number are also doing the same. Is dying costly in India? Yes, because 80% of healthcare spending in India is out of pocket. And in most of the cases, financial resources are spent on last few days of life to prolong, probably they don't need that medical intervention, but they are forced to do that. Maximum amount of money is spent on investigations, and out of spending pushes over 20 million patients into poverty every year. And this is out of my study I have just shared, okay? End of life care preferences. If you see, in my study, I did it with 120 terminally ill patients. Nearly 69.16% did not talk about, like end of life care preferences to anybody. And if you see here, the person whom they preferred for end of life communication was family members, and the second is the healthcare professionals. And this is regarding the treatment options. The majority, 82% wanted medicines to control pain, and 56% never wanted artificial nutrition or hydration. 72% did not want any form of intubation or being connected to a ventilator, and 72% never wanted CPR, and another 74 never wanted any latest treatment. Why am I showing all this is we don't talk about their preferences at all. Most of the time, nurses are not very comfortable in talking about this end of life care to their patients, to discuss about death and dying to their patients. And if you see here, the preference for place of death is home in majority of the patients. And the process of death and dying, they wanted early death. Most of the patients, 91% wanted early death, and they wanted to share. Half of them had, to share, and another half never wanted to share their fears of death. And, they wanted God to control their process of dying. And this is on the spiritual needs I've just highlighted, and based on the living will. In most of the Western countries, they have something called as advanced directives, where they'll be able to write about their preferences, end of life care preferences. But we don't have here, but there are a lot of legal proceedings that are being done towards it. And here, 72% said that they have preference to write a living will for their end of life. And as Angel was talking, this is the new integrated end of, meaning the palliative care model. And if you see here, palliative care starts right at the moment when the patient enters into the hospital, and when there is no disease-directed treatment, that's where the end of life care starts. And it ends with death, and the palliative care extends even beyond that to take care of the family during the bereavement. And if you see here, the palliative care is looking at all the supportive care, symptom control, and disease management, where it moves into hospice care with symptom control and supportive care, and end of life care is purely with symptom control. And if you see here, it is a continuum. You can't separate a palliative care and end of life care. It is a continuum, as we saw in the model. So end of life care cannot be initiated all of its own. It is an extension and a part of palliative care. We need to understand that. And entering the end of life care is a period of transition. So early and good palliative care facilities smooth the transition. And transition to EOLC involves recognition of end of life care decision making, the communication, and the initiation. And it doesn't involve the immediate life before death, but also involves a process of dying. As I said, the bereavement care, very important. I can quote number of examples where when the family is not supported beyond the death of their loved ones, the whole family is shattered because some of the family members, they commit suicide because they are not able to accept the death of their loved one. So it's important that we support them even in the bereavement period. So there is an enormous and urgent need to develop the EOL care in India, but the progress is slow. The reason is we have a lot of challenges. One is we have the healthcare professional associated barriers. I'm not going into the depth of it, lack of knowledge and all that. We have a lot of legal and policy barriers. We don't have clear legal framework. Certain palliative care organizations are working along with NGOs on towards this. There are a lot of societal barriers and the patient and family barriers and geographical. Because if you see, most of the palliative care or good end of life care is given in the urban areas. But what happens to the people in the rural areas? So there are a lot of, India has diverse geographical background. So these are some of the barriers for end of life care. So the need is more, but what is present is very little. So if we have to have good end of life care in India, we need to balance this. We need to restore the balance. And what can be done is, a lot of things have to be done in terms of nursing practice. A lot of research have to be taken up, and there should be a lot of strengthening in terms of education for quality end of life care. I've just given certain gaps in end of life care nursing research. The field of end of life nursing care is relatively unexplored. If you see, the number of nursing research in terms of end of life care, it is very less. And it is a top priority that is given by Institute of Medicine in the US. And there is underrepresentation. Probably if you see, you have some physical related end of life care research, but psychological and spiritual issues are underrepresented. Culture plays a very important role. And that is one reason why I went in for studying the end of life care preferences for Indian population. And there is a tremendous need to bring together nurse researchers and nurse clinicians in end of life care. And we need to remember that the care proponents of EOL care are looking to nurses. And we need to know that the number of terminally ill patients is on the increase, and there is a greater reluctance among nurses to discuss about EOL care issues. It comes with, the more and more you interact with patient, it becomes easy. You become very comfortable talking about end of life care to the patient. So what is end of life care? It is a multidisciplinary team approach towards total care of people with advanced, progressive, incurable or life-limiting illness, so that they can live as well as possible before they die. It is the quality of life that matters before they die. And here we include both the family and the caregiver. So what would be the objective is, the one objective is to achieve a good death, irrespective of whether they are in the hospital or at a hospice or at home, and emphasize on quality of life and quality of death. This is very important, and acknowledge that quality end of life care, how we say quality of life is a human right, quality of end of life care is also human right. It cannot be given to people only who are rich, who have that access. So every individual has a right to a good, peaceful and dignified death. And this is yet another definition. End of life care is provided to someone who is not responsive to curative treatment, and life expectancy to be within days or months. These are certain principles. I'm just quickly highlighting this. Family caregivers should be prepared, educated, and felt, they need to feel supported. Caregivers should be involved and empowered. This is very important. They need to be sensitized. Healthcare providers should be accepting and anticipating that the patient is dying. The reason is we cannot prolong dying. Achieve good control of pain and physical symptoms. Preferred place of care should be respected, and preferred place of care should be safe and secure. Healthcare providers should be comfortable, confident. So, I just like this. Life isn't a matter of milestones, but of moments, especially, towards the death. And this is my own conceptual framework. So when EOL care is fragmented, where we give a lot of importance to physical issues and we forget about all the psychosocial issues and the ethical issues, we are promoting a bad death in patients. But on the other hand, when we are giving a comprehensive end where we are taking into all the issues and we are keeping in mind the dying patient's bill of right, we are promoting good death in these patients. So these are 6 major components of good death. And I'm just going to, I'll highlight that a little later. So when I say good death, it is free from avoidable distress and suffering for patients, families, and caregivers. These are principles. Again, why am I highlighting all this is, again, like stressing that there are concepts like this. There are good death principles. Many of us are not aware of all this. What are these good death principles? To know when death is coming and to understand what can be expected, to be able to retain control. Patients want to have control even at that moment. Patients want dignity and privacy. They want to have control over pain relief and other symptom control. They want to have choice and control over where death occurs, to have access to information, to have wishes respected. See, why am I quoting all this is, are we looking into all these aspects when a patient is nearing his or her death? See, when I say pain and symptom management, there are a lot of measures, right? It includes pain, it includes shortness of breath or delirium, and clear decision making. We need to include the patient in decision making. We need to help patients prepare for death. What do they expect? And how do they want to plan for the events? I can quote a lot of examples from my own study. How, how as a part of my, like intervention, where I help them to plan for all these events. Completion, knowing the importance of spirituality, meaningfulness at the end of life, and dealing with faith issues, life review. I remember one patient, who had an nasopharynx cancer. He wanted to derive a lot of meaning. So he was interested in this, organic farming. And through over the phone, he used to, like at the end of his life, he used to counsel many of his students because, he wanted to have some meaning in his life, resolving conflicts. And I remember one particular patient in terms of this. He was my first patient. And this gentleman who was 67-year-old, he was dark by complexion, but like his face was really, really dark. And I was just wondering why his face is so dark. And when I started talking with him, he had a conflict with his elder sister, whom he had left behind in Burma, okay, when he was 18-year-old. Now the time when I saw him, he was 67. So he didn't know how to resolve conflict because he couldn't meet her. So what I did is I asked him to say what he wanted to say. As he said, I wrote a letter. I recorded what he wanted to say for his sister, and we posted it. Till today, I really don't know, because the family themselves didn't know whether the sister was living in that particular address. But that gave a lot of comfort to the patient. And once this was done, this took nearly 3 days of time, counseling for the patient. And once when that completed, the patient's, the face brightened, and saying goodbye. The same patient recorded each what he wanted to say to each one of his family member. And even today, that daughter calls me and says, thanks me every day. Ma'am, thank you so much for helping my father to have a peaceful death, contributing to others, and affirmation of the whole person. All these are the components of good death. And this is from my study, where 62% said that death without pain, according to them, is good death. But there are a lot of other things that patients have quoted. And please remember, as we have patients' bill of rights, we do have dying patients' bill of rights. And I hope that you're with me, right? Yes. Am I clear, participants? Yes?
Yes, ma'am. Yes, ma'am.
Yes, okay. And, like we talk about Maslow's hierarchy, usually in terms of other patients, but Maslow's hierarchy is also applicable to a dying patient. Just remember, do not, like this is very important. Do not count the days, make the days count. And this is, very important for patients at end of life. And remember, the suffering in end of life is not only because of a physical aspect, it is emotional, spiritual, and psychosocial. And out of my experience, if you ask me to rate it, I would rate emotional and psychosocial and spiritual the highest than the physical. I would like to quote one example. I had a middle-aged man, he was around 37 or 38 with, like I knew that this patient would die in another few days. And when I was talking to him, he was separated from his family. And this has caused a lot of psychosocial and emotional pain. And the children and wife were not willing to come to the hospice to meet him. You know, allowed him to cry. And I said, whatever it might happen, whatever you want to say to your wife, you say it now. And that patient, like cried and cried, and he poured his heart out. And I knew that lightened him up. And, the very next week, okay, he died. But I know that, he had a peaceful death. So what I want to say is, it is very important to focus on all aspects and all dimensions. And this is my own conceptualization. If you remember, all the dimensions are interrelated. If you have a physical issue that will lead to a psychological issue, say pain can lead to depression, and that can lead to an ethical issue called as physician-assisted suicide. So there is an interrelationship of all these dimensions. So it's important you address all these issues in the end of life. There are an n number of reasons for fear and anxiety in patients confronting death, and we need to understand that. And if you see here, it's not just physical pain. If you see the green boxes I've given underneath, it is physical, intellectual, emotional, interpersonal, spiritual, financial, bureaucratic. All this is happening in the patient. So I need to understand patient from this perspective. And I've given the 7 C's of care. All this, it's just a guide. But ultimately, you need to have that sensitivity. You need to have that. This is again, in nutshell, the physical aspect, what we need to do. It is the control of symptoms. Spiritual aspects, witty. And this is there are a lot of, models, but this is one simple model, peaceful EOL. See, it's all simple and very easy to understand. Not being in pain, experience of comfort, experience of dignity and respect, right? I remember one patient in, like in CMC Vellore when I was doing my PG, a very young girl, like she was dying, and I knew that she would die in the night. And I happened to visit her family and her in the evening after my duty and everything. And she started having melena. And when I went into her room, she was put on a bedpan. Even at that moment, she demanded privacy, and I had to wait outside, give her that dignity and respect. Please remember, you can't say a patient is at end of life. I can treat the patient however the way I want. We need to include them, and being at peace, providing emotional support, listening to them. Listening has something very, very important role in this end of life. And the last is, like contributing to significant others. And, this is again, I have put a lot of slides on this. The reason why I have put this is, it's not just physical. It is much more than that. Practical issues. How do you want to leave a legacy behind for the patient? A lot of patients, have that in their mind. This is my experience. How people are going to remember me. I had one patient, who was unmarried. And this patient had, like a wonderful voice. And she always asked me, will people remember me because I'm not married? What we planned together is, I made her sing, recorded that, and gave it to her immediate family members. So, like, how are we going to help these patients leave a legacy behind? Very important. And care at the end of life. Where do they want to die? And all that have to be planned. This is again the nutshell. If people are interested, you can contact the DSU, Dayanand Sagar University, Dr. Shamila, and you can get this, because this would help you to serve as a model. How do I want to, plan this end of life care guidelines? This is helpful for you. This is a process of care. And if you see here, the moment you take the patient, how do you plan, the ongoing care till the discharge? Okay, I'm skipping that slide. I'm just, going to highlight on few. I'm not going into the depth. Okay, what I want to highlight here is how important it is to highlight or address all these issues. Remember, physical issues, pain is a more terrible lot of mankind than even death itself. If you ask patients who are having the terminal illness pain, they will say it is better to die for, than, living. That is what they answer. So it is worse than torture. If you see here, there are a lot of, torturing instruments. It is worse. The pain that you undergo through these torture instruments but is lesser when compared to the pain in the terminal illness. So mostly what happens is it is undertreated, underestimated, or overlooked. We have this. This patient is always complaining. We can't say that. Pain is what the patient says hurts. So this, erodes the quality of life, and it has an effect on all aspects. It can cause depression, suicidal ideation, anxiety, impaired concentration, and whatnot. So it is important to address this. And remember, pain, when we have the visceral pain, neuropathic mechanism, all these are biological mechanisms. And apart from that, the suffering, these two together can cause total pain in this patient. That is the reason it's very important we address all the dimensions. And this is a simple thing. Search for cause, treat underlying cause, treat symptom, and re-evaluate. And I hope, Selma would be dealing with the nurse's role in each of this. And this is, like when patients say pain, listen and believe to them. Assess, involve, and then which will have an impact on the patient, and we can further reassess. Apart from pain, there are other symptoms that we have to look in. Weaknesses, fatigue, constipation, dyspnea, nausea, depression, delirium, lot of, concerns in this patient. So if you don't ask, you won't know. So routine assessment is very essential in a good symptom management. Psychosocial issues. Many a times, physical issues are given a lot of importance, but restoring the balance is something very important for quality EOL care. This is my personal experience, especially when they die, when they are nearing death. Okay, I'll show a few of what interventions I did for the patient. There are a lot of psychosocial and spiritual issues that run through the mind of patient when they approach their end. Why treat this psychosocial distress? Because it impairs their capacity for pleasure, meaning, and connection. It erodes their quality of life. It amplifies pain and other symptoms. It reduces the patient's ability to do emotional work. They won't be able to separate from their loved ones. It causes anguish and worry in family members. Particularly, depression is a risk factor for suicide and request to hasten death. So what do I need to do? This is, I just like this slide. Purposeful observations. When I go near my patient, if I want to assess psychosocial and spiritual suffering, I need to be very purposeful in my observations and in my conversations. And remember that it is a very, very expansive and an expensive also concept than pain. And remember, this causes most of the suffering, and it is most difficult to treat, and it requires intervention by both clinical as well as non-clinical staff. I've just given what are some of the spiritual suffering associated with emotional and spiritual suffering: anxiety, depression, helplessness, they are lonely, financial distress, meaninglessness, need for forgiveness, fear of the unknown, loss of important roles, lot of conflicted relationships, hopelessness, inability to enjoy or celebrate, and need to forgive. And these are some of the roles that we can take up. This is the conceptual framework of my study. I'm not going into it. These are the interventions that I did for my patient. Emotional ventilation in all the patients, dignity therapy in all the patients. It's easy to talk here, but I know like the amount of time, it's almost, like I spent 4 years of data collection for this particular study. I would go on Monday morning, I would start with end of life counseling for patients. And by Friday or by Wednesday or Thursday, I would be drained listening to their stories. It is such, such tedious it is, okay? But with practice, it becomes easier. Information on end of life symptoms. Even now people call me, Deva, there is my elder, at home who is 80, who has all these symptoms, not taking diet. I said, leave them just as it is. Because I know towards the end of life, I cannot force fluids or food in patients. So information was given, spiritual support to 38 patients, conflict resolutions, need to have a lot of patience, leaving a legacy and arranging for unfinished business. I like this. Look at me when I'm talking to you. So listening is a key aspect if I wanted to give good end of life care, because they are not looking for answers. They just want somebody to listen to. Please remember, when patient is asking, see, like whether this thing will go off, whether my pain will go away, or, they are not looking for answers sometimes, most of the times. They wanted you to, someone to listen to. So words from the heart enter the heart. Remember, that's what I was talking to about purposeful conversations. Considerable suffering is caused by poor communication, and much of this is very important during end of life. If you're not able to deal, better to refer to somebody who is good at it. Okay, so I'll be aware of this. A quick thing on ethical issues, because ethics in end of life in itself is a huge area. But remember, when I wanted to provide comprehensive end of life care, I need to know about the ethical dilemmas, because nurses are the first one who encounter this. If the patient is in severe pain, they come to you and say, like, I wanted to die. What do you do at that time? Because most of the, like ethical dilemmas are faced by the nurses first. And that is the reason we need to know a little bit of the ethical issues at this point of time. And we know the ethical principles. And if you see here, there are informed consent issues, decisional capacity, where they are not able to make any decisions, advanced directives, prolongation of life, balancing the benefits and burdens, withholding or withdrawing, can I withdraw? We are not directly involved, but as a nurse, I need to know that these are the ethical dilemmas: medical futility, assisted death, euthanasia, principle of double effect. See, all these are some of the ethical issues. There is a model bill that has been prepared by Vidhi, which is an NGO, along with, I think it is with Indian Association of Palliative Care. And soon, there will be changes at the legal level also, because, this is one area where people have been demanding for specific laws and the policies related to end of life care. So there is a lot of conflict when there is a loss of decision-making capacity by the patient. So the decision-making capacity goes in the hands of the relative. So there can be conflicts that arises because of misunderstanding of prognosis, differences in values, loss of trust. So how do I do it? Education, clarifying the goals and intent of the patient, and encouraging the team approach. You need to have a direct, conversation with the family members. And this is where the advanced care planning, and I was going through the model bill, they have given importance to advanced directives also. Okay. Now, I just wanted to highlight, I know like Selma will be doing it, but I wanted to highlight a little bit of end of life care, nursing care. Patient and family preference for treatment and care should be discussed. Undesirable symptoms should be relieved. Please remember, it's not just physical care. Emotional, spiritual, and personal suffering have to be addressed. Patients and families have to be prepared for death, and grieving has to be acknowledged. Okay, you need to support the family also. So as a nurse, she'll be a skilled technician, guide, and an advocate. These are the skills that are required. And if you see here, communication skills, I have to be trained to talk about life and death. When to say nothing. How do I use this therapeutic comforting touch? I remember one patient, 2 days, I went to interview that patient and to counsel that patient. That patient was quite well. Third day I went, I knew that the patient was in severe pain. I sat there near the patient and spent 1.5, hours talking nothing. I was just holding her hand and patting her back. And the very next day when I went, that patient said that meant a lot to her, because in that pain and in that loneliness. So, use your therapeutic comforting touch with confidence. Teamwork skills are very important. Physical care skills, active hands-on care. And I know that Selma would be dealing that. Psychosocial. We need to deal with families. We need to anticipate what is there in their mind, for which, an appropriate communication skills is very important. Purposeful communication is very important. Intrapersonal. What is your personal reaction? For me, when I did that study, it was very difficult for me. I would become very emotional. And then, as days went by, I knew where to draw a line, but I remember end of life care many a times requires extra miles that you have to walk. Okay. So it is a most challenging area. And these are some of the consequences. When I have good end of life care, what happens is it increases the coping, it increases the quality of life, relief of suffering and symptoms, human dignity is enhanced, and effective closure. Please remember, effective closure is very important for a good death for the patient as well as for the family members who are left behind. And for family, it is an effective closure, improved bereavement, and healing of relationships, decrease guilt. The family need not feel that I did not do this for the patient. Decrease psychosocial distress on the family and improve coping. So I've just given the scope of palliative care. This is end of life education material that is prepared by Indian Association of Palliative Care. If you go to the net and you search, you get that. But I just wanted to say that these are certain things that are available. If I wanted to start a policy on end of life care, all these are available. And this is the way forward. This is again by Indian Association of Palliative Care. They wanted to have advocacy for end of life care. On end of life care policy, they wanted to frame. Lot of work has been going on in this, and process of end of life care, how to improve, and implementation of end of life care at grassroots level, and developing EOLC standards and EOLC education. I've just given the highlight of all those again. Just remember, okay, I've just given few of my experiences. It's probably, if you give me one full day also, I'll be able to talk on this aspect, because this is something very close to my heart. But owing to the time, okay, please remember, it requires a lot of sensitivity.
Ma'am, kindly check with your network. Ma'am, we are not able to hear you. Deva ma'am. I think madam has ended up with some sort of technical issue. I request the participants to kindly bear with us a few seconds, where madam will be back. Deva ma'am, you're not audible, madam. Ma'am, ma'am, you're not audible. I think you're mute. For past few minutes, we were not able to hear you. You're mute the audio.
By itself. Can you say, Sharmi, from which slide I was not audible?
Yes, ma'am. From last, like compassion you were talking about.
Oh, right. Fine. Okay. Did you all listen to my talking about the student that I was talking? No, right?
Yes, ma'am.
Yes.
No.
Yeah. Compassion is more than just a job. Sometimes the patients just need a touch on the hand, a touch on the shoulder, a smile. I remember, working with the first year student where we had a patient who did not have anybody and was lying on the floor because he didn't have a bed. And I, encouraged this student to give a good physical care for the patient, but the student was so scared because, the patient was so dirty and terminal stage. So stood with the patient, helped the student to give the full care for the patient. And I knew that the patient died the next day. And this student came to me and said, okay, that was so satisfying for her. This is what you can do being a nurse, helping the patient to have a peaceful death. I'm just talking one aspect. So why we do what we do is no one else can die for us, but we don't have to die alone. That is why I'm here. Our patients' journeys are our journeys too. Please remember, one day we also have to go through this path. And a comprehensive and compassionate EOL care is a holistic approach and a team approach. And this is one of the loveliest quote that I really like, held by Helen Keller, who was a born blind and deaf and dumb. Although the world is full of suffering, it is full also of the overcoming of it. And God has given us that wonderful gift to be a nurse, to reflect the love. Okay. And if you see the one quote, we can cure physical disease with medicine, but the only cure for loneliness, despair, and hopelessness is love. Please remember that. And I hope that as a nurse, we will be able to make a difference wherever we are, in the hospital, hospice, in the nursing institution. Train your students to care for the terminally ill patients with compassion. And thank you for your patient listening, because this is the crux, the comfort, dignity, compassion, caring, and support is the crux of end of life care. The end of life care deserves as much beauty, care, and respect as the beginning, one is born. And that's the end of my presentation. Thanks for your patient listening. And these are my references. And over to Dr. Shamila.
Thank you, Madam Dr. Devakrubai, for a detailed explanation of end of life care. And also, the best part is you have explained or you have shared your experience with the patients, whom you have come across and whom you have cared for. And also, you have beautifully explained the 3 C's on about the care, the communication, and also about the last aspect of the compassion aspect of it, which is very, very important in everyone's life. And also, as a nurse, whom we have to possess all these skills to be a very good communicator and a good listener too. With this, once again, I thank Dr. Devakrubai for spending her valuable time and explaining us in detail about the overview of end of life care. Now I request the participants, as ma'am have to leave for an urgent work. I request the participants, if you have any questions, to write now to post in the chat box so that you can clarify if you have any doubts with Madam Dr. Devakrubai. Ma'am, I think we will give a couple of minutes.
Sure, Sharmi.
Because they may be thinking, as I've
Sure.
already mentioned, they may be thinking at the end, they may ask.
Yeah.
If you have any questions or any queries, kindly post it in the chat box so that it will be easy for us to ask. And there is a lot of appreciation and applause for your presentation. I don't think so.
Sharmila, Sharmila, I think I'll wait for some time, and I
yes,
think Selma start. I think that
yes,
will be
ma'am. Yes, ma'am. Yes, ma'am.
Thank you.
I'll do it, ma'am. I'll do it, ma'am. Right. Thank you, Dr. Devakrubai, for giving us this wonderful session. And I'll move on to the next participant. The next speaker. I'm very sorry. I would like to invite the next speaker, Miss Selma Thomas, to talk on nurses' role in palliative care. To talk or to tell about Madam Miss Selma Thomas. Madam has completed her undergraduate and postgraduate from Christian Medical College, Vellore, She has completed an MA Psychology in Annamalai University. Apart from that, she had other certificate courses on Certificate in Essentials of Palliative Care in 2009 in Indian Association of Palliative Care, Trainers Training 2009 in Indian Nursing Council, Program in HIV and AIDS, and then Certificate in Clinical Counseling at Madras University at 2010, certification in Coherent, workshop on content review, then certification. Madam has completed her NABH assessor course in 2018 in Quality Council of India, executive diploma in healthcare management at Loyola Institute of Business Administration and CMC Vellore. Right now, Madam is pursuing her PhD in Tamil Nadu MGR University, and also to add to her credentials, Madam has a vast experience from the post of tutor to the chief nursing officer level. And also she is a member of TNI, Nurse League, Christian Medical Association, and also Alumni Association of CMC Vellore. Madam has been awarded as a best clinical nurse, best case presenter, best trainer in GF ATM, and also Madam has organized and presented in n number of conferences in national and international conferences. And right now, Madam is working as the nursing deputy superintendent of Ramchandra Medical Hospital, Porur, IP operations. With this, I welcome Ms. Selma Thomas to talk or explain us a nurse's role in palliative care. I welcome you, ma'am, and over to Ms. Selma Thomas. Is Ms. Selma Thomas here?
Dr. Sharmila, am I audible now?
Yes, yes, please.
Thank you, Dr. Sharmila, for those pleasant words. And for a moment, I thought you were ragging me. and, and Angel and Dr. Deva, it was splendid listening to you both. And I really enjoyed listening to you both. And now I'm sorry, I cannot take my mask out because I actually hit the COVID segment of the hospital. So even in a closed room, taking off the mask is a bit risky for us here.
Few seconds, you open your mask and show your face, ma'am, so that you will be happy, all of us, to see your face.
They'll actually, I'll have to pay a fine if I take off the mask.
Thank you so much to show your beautiful face.
This is the person Sharmi has been giving an elaborate introduction about. So Sharmi, can you just share the slides for me?
Yes, yes, yes.
Thank you so much.
Manimegli, you are able to share? Ma'am, 1 second, ma'am. Just you can keep talking.
Okay. So when we're talking about palliative care, actually the previous two speakers have wonderfully given a beautiful introduction to, and they have taken you through the end of life care too. In fact, they've covered 30 to 40% of my content. So let's quickly skip through the slides, and it'll only be a recap to whatever we've learned today. So just keep your ears open and give your ears to me for a while, and I may not bore you for some time. So when you're talking about palliative care, we must think of, I was actually a critical care nurse. So for me, it was like, when a patient is ill, when a patient is arresting, all the time we think of only the early warning signs and a deterioration in their vital parameters. And the first thing that comes to our mind is, how are we going to take care of them? The first thing is, where is the crash cart? Where is the suction apparatus? Where is the oxygen? Where is the oxygen connection? Where is the laryngoscope? Where is the defibrillator? Are we having the right sizes of the ET tube? And all these things. And what's the age of the patient? And do we have the right sizes? And what is the need? And how are we going to shift the patient? Which ICU? And what are the drugs needed? How many inotropes are we going to pump in? These are the things immediately when a patient is sinking used to come to my mind. And I think for all of our nurses, that's what we learned, right? For Code Red and Code Blue and all those beautiful knowledge that has been pumped into us. With Code Blue and MET, and I know every nurse here is trained in it, and we know how our mind works, right? But for palliative care, our mind has to rest in itself. And we must, first of all, accept. first of all, accept that it is a way of life and we are part of way of life. And life and death is normal. Life and death is normal and we have to accept it. And we have to go all our way on how we are going to enhance our life and the way we live until our death. Next slide, please. So we're not talking about active patient care, but we're talking about a symptomatic management of what is actually bothering us. So this has so next slide, please. So this has been beautifully taken, or Professor Angel has beautifully taken it through the history. The next slide, please. The next slide, please. So when we're talking about palliative care, we know we are concentrating on the quality of life and we are concentrating on prevention and relief of suffering. So these 2 points we need to have on and relief of suffering. Next slide, please. So when we know this is not only for a particular condition, because when we're talking about palliative care, we often think about cancer. And here also I would like to concentrate because on oncology and other aspects of cancer management and other things. But let me tell you, there are so many patients right now, even now when I'm handling COVID cases, I know how much the lung has been fibrosed and how much the patient needs care. But what can we do? We are just trying to support him symptomatically. We are hoping for the best and continuing with the management. But in our heart, we know what is actually happening to our patients. So as the curative model sinks, the palliative model increases. Next slide, please. So in this, we must know that our main aim is to reduce the suffering that is avoidable and to concentrate on what can be done for unavoidable suffering. So let's the main aspects that we will be concentrating on how we are going to improve their sense of well-being and how we are going to promote their comfort and how by providing comprehensive care. So next slide, please. So when we're talking about nurses' role, so as a nurses, how many of us have felt very proud being an ER nurse or an OT nurse or an ICU nurse? And how many of us have actually looked down upon OPD nurses? Right? So we even within nursing, we actually have so much of disparity. But let me tell you, in OPD, we need the best nurses because they need to have the best assessment skills. And that's the same with palliation also, because we are going to manage with symptoms. And symptoms have to be recognized at an early point, and we need to take care of them. So we need to have good assessment skills. And then we need to have a plan. So how are we going to handle these symptoms? And how are we going to support them emotionally? And how are we going to communicate with them? There are a lot of ethical decisions that we need to be concerned about. You know, we do have a legal system that does not completely support the healthcare professionals, but there is we can have some clauses by which we can protect ourselves by proper consents and other things. And we should also, you know, the person's immunity may be reducing and all those things. We have to have a holistic idea about where the patient is and how we're going to take care of them. And next thing is, you must know it is actually how we are organizing our healthcare and how we are organizing a hospice, okay, or a palliative care. In the palliative care, our concentration completely changes from an acute immediate care to a long-term care. So in that, even the way we actually distribute the financial aspect of on the instruments, on the stuff, everything actually changes according to the patient need. Here, you may not be concentrating on the inotropes and the ventilators and all those things, but you will be concentrating on their symptomatic management. You may even have to have some units where you may have to, a small surgical unit, a small radiotherapy unit, a small chemotherapy unit. It's not on the curative aspect, but on preventing, on reducing the symptoms. And the resources have to be channelized on a different level from a curative part to a palliative part. And monitoring is very essential because we really have to take care of patients until the end, not only the patients, but also their relatives. And education and training and research must be continuous, not only for the care that we provide, but also to strengthen ourselves and make sure we are giving the right kind of care. So next slide, please. Next slide, please. I think we've gone to the previous slide. Next slide, please. Next slide, please. The following slide. Following slide. Okay. When we talk here, okay, fine. So when we're talking about the previous slide, please. So palliative care approach, we must know that we're taking care of the dying person as well as the person along with them, the significant others. There was a case where a child was an oncology patient and the child was hemato-oncology, and the child required a bone marrow transplantation or a cord blood transplantation. So the young mother, actually the baby was on chemotherapy and radiation therapy and all the other possible therapy that can be given for a hematological oncology. But what happened was the mother was told that a bone marrow cord blood transplantation would do because the child was a single child. She got pregnant, she had another child, and with delivery, the cord blood was taken and the cord blood transplantation was done. What happened was, very unfortunately, the baby died. And the mother was not able to take it at all. Suddenly, we found the mother missing. What happened was, she had left the newborn baby and the mother was missing. And we went and searched everywhere with police complaint and other things. And she had actually fallen in front of the train. These are pathetic things that happen to those significant others with the patient. We should be very concerned about not only the patient, but also those with them. And when we're talking about an autonomy and choice, Dr. Deva had done an excellent job of how much of a patient's preference has to be taken. So there was a time where one of our patients, she was another hemato-oncology patient. She had actually had bone marrow transplantation twice, and both the times it was a failure. And she had 3 siblings, 2 sisters and 1 brother. And the last was the brother, and she loved her younger brother so much. And the 2 sisters had donated bone marrow, and both were failure, and this girl was sinking. At that point in time, what happened was that the doctors had suggested that we take the bone marrow of the little boy and then transplant once again. That this girl refused. She said, "I know I'm going to die, and I don't want anybody laying their hands on my little brother. I love him." She was very close to me when she was patient. Throughout her stay, I was taking care of her. On the day when she was dying, she was close. Her parents were with her, her sisters were with her, and her brother was with her. She started having a high spike. And when I went to meet her, she said, "I don't want to meet anybody." It was very hurting, but I know what she was going through. I may not have a clear understanding, but there was so much of pain in it. And those who are taking care of such patients will also experience the pain when you have been really close and you've been taking care of them. And palliation, it is a right of, next slide please. It is a right of every patient. And every healthcare, it is not a palliative care nurse. It is not an ICU nurse. It is not a ward nurse. It is not an emergency nurse. Palliation is the responsibility of every nurse, every healthcare worker. From the time the person comes in, we must have that on our mind. Next slide, please. Death. How many of us have actually thought of our own death? During a counseling session, they actually ask us, what do you want to be written on your tombstone? When you're buried, we have a tombstone, right? So they ask us, what do you want? Just imagine that you're dead and who all you think you want at your funeral, and what do you want to be written on the tombstone? When you start imagining, it really starts, it really starts sinking into you what it is to leave the world and go. Fine. So a lot of times when I work with the COVID patients and they are isolated, and when I find them dying with no significant person of their own with them, it really hurts me. I often tell myself, I don't want to have this death. I don't mind dying, but at my death, I want those I love with me, right? So it is very painful. So 56% of the people want to die at home. And a very small population actually want to die in the hospital. It's not that they want, but they want to be taken care of in the hospital. During the process, they die, and 24% die in the hospice. Why in the hospice? When we are talking about their symptom management, we will clearly understand why they actually want to die in the hospital. Next slide, please. So I've been thinking about these symptoms. One is cancer, the other is non-cancer. So palliation is for many other conditions. Actually, I was a CTVS nurse, and I have worked for heart and lung transplant unit. There are so many patients who actually are in their end stage cardiac failure, and at that time they will actually, I've seen some of my patients die just waiting for a heart, just waiting for a heart. Right? So that's why I repeatedly say, when you're thinking of palliation, it is for any clinical condition that we should have our mind on. So symptoms may be similar, but the percentage in which they experience may be a little different. Next slide, please. So we'll be talking about these aspects of nursing care. Next slide, please. When we're connecting, I would suggest that we make a connection with the patient, build a trust with them, and remember, we need to be available. It is not like every case, like I'm taking care of 10 patients and I spend a few minutes with everybody. I gave medicines, I checked their vitals, I started an IV, I gave some injections, and no, that's not the care. Here you need to spend time with them. The time that you spend makes a lot of difference. And when it's time to say bye, you must emotionally separate yourself from them. It's a very difficult because it's a long-term care. We kind of get very close to them, and it really hurts us when we have to leave them, when they have to leave us. Okay, so we must prepare ourselves for that emotional separation too. Next slide, please. And we must empower them, facilitate whatever period they are living, they must be able to take care of themselves, even in a small way. There is some food on the plate, right? Even when they are able to take one mouthful with their own hand, it makes a lot of difference. When they are going to the toilet and when they are able to wash themselves without the help of someone, that makes a lot of difference. When they are able to take a glass of water and drink the water without someone's support, that makes a lot of difference. So recognize what they can do, encourage them. When they have, I cannot, and I feel down, and I don't think I will live, and why should I live? And this is too much of a suffering. I'm not able to manage. When these negative thoughts come, you divert them, diffuse the situation, and handle it. And always make sure your focus is on their healing. Healing is and curing are totally different. There is an inner healing that happens, and they are able to accept and depart in peace. Next slide, please. Next slide, please. Yeah. So preserving the integrity. And one more thing, I just really have to tell you, when you think that you're not able to, when you are physically down, when you are emotionally down, when you are drained, I would plead with each one of you never to take care of patients requiring palliative care. because we will show our own disgust and our own pain on them. We will thrust it on them. We will be impulsive. We will be impatient, and that will hurt them more. Ask yourself, what is your feeling about death? Ask yourself, am I strong enough to take care of the other person's pain? Ask yourself, and then step into it. And burnout is very common, frequently, and very often when you're saying patients die in front of you, and especially patients of the younger age dying in front of you, it drains your energy. So ask yourself, am I physically and emotionally strong enough to take care of patients? And always remember, we have to lift each other up. So support your colleagues, support each other. Definitely, each one of us can strengthen each other and take care of the pains of the patients. Next slide, please. The one thing that we can give is hope. Like hope is the last thing in our life, right? So one thing we have to know is we have to give hope to our patients. And how do we have to, from what they are draining, we have to make sure until their end it is being sustained. Next slide, please. Next slide, please. Next one. Next slide, please. Okay. Now for the, as a nurse, let's concentrate on a little bit of the physical aspects, because we really need to know what it is, right? So why should we actually take care of patients with palliative care? What is their expectation? What do they want from us? One thing is we need to relieve any distressing symptom. We have to make sure they understand dying is normal. It is neither, hastening, like giving some lethal injection, or, assisting with suicide. It is like there is a death and we are just supporting with it. As long as they can live, they live with it. And we are integrating other psychological and spiritual aspect. And we allow them to live as actively as possible until their death. And we help the family cope with it. Next slide, please. And how do we do it? We have to, first of all, establish a relationship. We must be really empathetic. We must be one with them. We must understand their pains. We must be able to assess properly. We should be able to find out what the symptoms are and take the control measures. We must allow utmost dignity and self-esteem. And even at the time of dying, remember they are human. They're just like you and me. At a time I know the patient is actually sick and is not able to move himself in any way because it was a neuro disorder. And let me tell you, when people came to change the sheet and give him a bath, what they did was, there is one female nurse and two male nurses who had come inside. What they did was they completely stripped naked the patient. He's not able to move his hands, he's not able to move anything, he's not able to speak anything, but he knows he's stuck naked in front of others. Dignity is very important. Though they are dying, we have to let them live with dignity. And they should not have this feeling there's no one with them. Talk to them, be with them, let them know there are people who are still supporting them. Next slide, please. What are they looking for? They're not, it's not being a yo power, it's not being sympathetic, it's about empathy. We listen to them, give them that smiling face, and make them feel happy in your presence. Happiness is very important. Make them feel happy in your presence. Next one, please. Next slide. Okay, now let's go on to some symptom control. So they generally have a general discomfort. So giving them a bath every day, making sure their skin is not dry, giving them a oral care, and sometimes the oral care may be difficult. So there have been times where we had to really lock jaw they will have. So we had to open the jaw and then give a mouth rinse and then suction it out. So you need to know the means and ways by which even when they have a locked jaw, or when their mouth is infected, how much effort you're taking to keep their oral cavity fresh. You have to lubricate their tongue. Eye care. There are times when patients are bedridden, patients are not able to move, and patients are sedated, or patients are kind of they are immobile, they're not even able to close their eyelids. What we have to do is put the eye drops and close the eyelid. What happens is patient is still breathing and living, but what happens is the eyes have been it's really dry. The cornea is dry and gray in color because we have failed to give eye care for the patient. Next slide, please. They have this feeling of tiredness throughout. So make sure you're conserving the energy and helping them use their energy effectively for even small activities that will give them the sense of, yes, I've done something. Help them with that and space your work in such a way there is periods of rest in between. Next slide, please. Next slide, please. Nausea. So nausea is a very, very annoying symptom. So when they have nausea, what happens is they're not able to, the very thought of food actually nauseates them. You don't have to bring anything for them. So we'll have to make sure, next slide, please. Okay, sorry. So we should make sure frequent oral care is given. So even plain lime juice without sugar, if they are able to just gargle and spit it out, that gives a feeling of freshness in their mouth. Just pineapple. If you're just allowing them to just suck a piece of pineapple, that gives a feeling of freshness to their mouth. Lime juice is a fantastic one. Lime without any salt or sugar, just dilute it in water, take a half a tumbler of water, squeeze half a lime in it, just make them gargle. It really makes them feel a lot fresher in their mouth. And avoid and foods that causes acidity. If you make it them drink, what happens is the hydrochloric acid. So it causes a lot more worse feeling of nausea. And ice chips, when you just put it a small chips of ice, when you put it in their mouth and make them suck it, it actually feels better for them. Next slide, please. Constipation. It's a very, very annoying symptom that they may have. And they may not be able to eat properly. They may have a problem with fluid intake. All these can actually result in constipation. Passive exercises can be encouraged. And exercises, whatever they are able to do, even the simplest ones can be promoted. And stool softeners may be an essential part of their care. Next slide, please. Next slide, please. Diarrhea. Diarrhea is another aspect. It may be related to a colon cancer or any other, a colon abnormality or anything else. But we must also be able to know whether it is related to diarrhea or is it related to fecal impaction. When we're having a high fecal impaction at the higher level, what happens is the mucosal secretions actually come out as the watery content from the rectum. And most often it is misidentified as diarrhea. And what we do is we treat for diarrhea. That actually what happens to the patient is they are having a higher level fecal impaction. A digital evacuation may be necessitated at that point. And incontinence is another thing. So what happens is it always results in skin breakdown. We should be careful about catheterizing or making sure the patient is feeling clean at the time. Next slide, please. Nutrition. They are not able to eat at all. Let me tell you, they're not able to eat at all. Sometimes we often tell, right, as nurses to the patients when they're telling, you shouldn't eat this. This is as a hypertensive, you shouldn't take this. As a diabetic, you shouldn't take this. As a patient with end-stage renal failure, you shouldn't take this. Right? So we often give them a list of do's and don'ts on dietary needs, right? When we are educating. But when it comes to palliation, we really have to flex ourselves a little bit, right? We have to make sure what they like, they are able to eat. It may be the last time they are eating, right? There is always the possibility. So whatever they can eat, whatever they like to eat, you can give them the option. So even in a palliative care center, you can permit home food that can be brought. At the same time, if it is causing aggravation of symptoms, for example, if the nausea is getting worse and if they're having severe vomiting, at that time we have to tighten it. So you can give them small frequent feeds, a bland diet, or sometimes you can ask the family to sit around them and feed them a few mouthfuls. So that will actually improve their nutrition. Next slide, please. Dehydration is very common in them. So antiemetics may be necessitated, and mouth care is very important for them. As I told you, sips of water, ice chips always makes a lot of difference. Next slide, please. This is one of the symptoms where all patients actually think they're going to die the next moment. The minute they have a difficulty in breathing, the first thought that comes to their mind is, yes, I'm arresting. I'm going to die the next moment. It is really painful for them because they know that they are sinking and the next breath is gone. So at that time, we should be very, very encouraging to them. We should position them, give them oxygenation, and we should make sure their anxiety is reduced in such a way that they start having a normal breathing pattern. And when you're there with them and when you keep encouraging them and talking to them, it actually makes a lot of difference. Next slide, please. Pain. Pain is one major concern. So according to the WHO step ladder model, the pain medications can be given, and one of the most common pain medications that is given in a palliative care unit is morphine. Morphine tablets are given. Some patients, according to their pain level, it actually comes anywhere between 20 milligram to 240 milligrams patients may take in one day. It is according to their pain. It is one of the symptoms which every patient who requires palliative care has said. And it is not related to a particular pathology. It may be generalized pain. There is so much related to pain. And one thing we must remember is when you're giving morphine tablets, it doesn't cause the normal reactions of a narcotic. There is a lot of pain relief. There is they do feel sleepy, but they do not feel drowsy. They do not feel addicted like when we're giving an injected morphine. So this with proper this can be given as a self medication, and properly it must be taught to the patient and given. And according to the pain, the morphine doses has to be titrated. There was one of our patients. He was 25 years old, and this boy was actually getting somewhere around 240 milligram of morphine, and it was extremely painful for him. And one day, what happened was he couldn't bear the pain anymore. There is a small church. He went and sat there at the last table, and he lied down there. And the father there, he came out, and he was talking to this boy for some time. Then he said, "Father, I just want to sleep here for some time." And I haven't slept for 2 weeks. Then father said, "Okay." And they didn't disturb him. This boy slept on that table for almost the entire afternoon. And after that, he just woke up and he walked back. And after walking back, he said, "I don't have pain. I feel good." And then he said, "I want to go back to my family. I want to spend some time with my family." Then from the hospice, he went back. He was taken back by his family and he lived with them for 1 week. At the end of 1 week, his symptoms aggravated and he died. But still, that 1 week was memorable for him, right? So it is memories that we create. It is pain that they undergo. But how are we going to relieve it? How are we going to make it pleasant for them? Next slide, please. Wounds. We must be careful about wounds. Wounds are something that we were talking about something. Why are 26% of the patients, 24% asking for a hospice care, right? So this is, next slide, please. This is one major reason why they want. The most of the wounds are in the upper body, and it may be a pressure ulcer, and it is usually when we're talking about wounds, we must know it must be holistic, and patient must feel good about themselves in spite of seeing their wounds. So how are you going to dress the wounds is very important. Next slide, please. It is not to scare you, but I want you to know these are some of the wounds that a person in palliative care will have. Some of the, can you see the ulcers? So this is the level at which you will be seeing. When you're seeing these ulcers, that you must understand there'll be a lot of maggots. There'll be a lot of exudates. There'll be a lot of stench. Everything emanating from these ulcers. How are we going to dress them? Just imagine the kind of stench that comes from these wounds. Where is the wound? It is on the face. Where is the nose? It is there. Won't they be able to smell it themselves? How are they going to feel with it? Right? So we must have utmost empathy when we have to see these patients. Next slide, please. So these are problems that they will encounter because of their wounds. Next slide, please. So how are we going to handle it? So what the problems will be, one thing is a girl, she was 18 years old and she had a cancer that was related to the jawbone. Fine? And that had invaded into the sinuses, and one side of the eye was gone, and she was a beautiful girl, and it was so grotesque that she was not able to see herself on the mirror, and she stopped seeing the mirror, she stopped coming out of the house, and she shut herself into a room. Okay, so there is a lot of, they feel that they look bad. There is a very bad idea that they have about their own self-image. So consider their psychological aspect, and sometimes their own relatives are not able to see them. Isolate the patient themselves because they are maggots and stench, and they are not able to take care of them. Next thing is, if they are young ladies, when they are having such kind of, their physical image that has been marked, they are not able to, their husbands may hate them. Excuse me. If it's the husband, he always feels the wife may reject him. So all these can go on in their lives. And when they look at themselves, the looks matter for them. When they look at themselves and they look so horrible, what they feel, why their God has punished them. And what have they done? So that is the feeling that they have. There's a lot of pain, a lot of stinking. They may have infection. Sometimes what happens is it erodes, and there's a lot of bleeding from the blood vessels. Sudden bleeding, massive bleeding they may have. Next slide, please. It will be extremely distressing, especially the disfigurement that they experience. And there is a lot of fear of bleeding from the wounds, especially wounds that are there. We had a patient. What happened was he actually had a laryngeal tumor, and he was put on tracheostomy, and we were taking care of him. Suddenly, what happened was, as the nurse was entering the room, the the tumor had actually eroded the carotids, and it was a carotid blast. As she was entering the room, suddenly she couldn't even speak. She started screaming, and when we all went inside and saw, actually it was a carotid blast, and from it the blood was actually skyrocketing. It was reaching the ceiling. Think of a situation as nurses when we really were stunned. We didn't know what to do. Actually, at that point in time, all of us are just looking at it and taking a particular bed sheet and even pressing against the carotid. It took a couple of seconds for us. Think of the relative who was seeing that. Think of all the blood. Of course, the patient passed away that day. But think of the distress the family will go through. Think of the memory that they will have, or all the blood splattered all over. Next slide, please. These are such situations for which patients come to the hospice. 70% of them may require wound care. And sometimes 5 times, 6 times, we may have to change the dressing. There'll be so much of oozing and so much of stench. And usually, if you see, when they bring them for wound care to the palliative care centers, when there are a lot of maggots, and they themselves are not able to see the patient, That is the time they bring. Next slide, please. I just wanted to show you the hospice where all of us were trained. So this is a nice, beautiful place. It's actually in the middle of a beautiful mangrove, and they actually have. It's all free of cost for the patients who are coming there, and they have a beautiful garden from which they grow their own vegetables and cook for their patients. And the surrounding locality, whatever donations that they can give, they give for feeding the inmates. And next slide, please. This is the surrounding, and these nun sisters, I really have a lot of respect for them, because the kind of wounds when you see it, really, I don't know if I have the strength, but I had to really muster the strength to do a couple of dressing. But these sisters, day in and day out, 5 to 6 dressing changes, everything, they take care of it very beautifully. There is no facial grimacing. I've never seen them, all the time they have a smile on their face and they take care of the patients. Next slide, please. Okay, so how are we going to take care? So just like dressing, make sure there is these are extensive, make sure there is adequate privacy. You spend a sufficient time. You don't run in between to collect articles, and you have to protect yourself. So universal precaution is a must. And most often we prefer using normal saline to betadine or hydrogen peroxide, because that is better on the tissues. Normal saline is better on the tissues. Only when we need debridement, we may go for other modes of management. And we may have to give a lot of absorbable pads to absorb the exudates. And there must be, especially the wound margins, we have to take care of it very well. And even the slightest facial grimacing is going to hurt the patient. So be very careful about what your expressions are with them. Next slide, please. Pain is excruciating when you're dressing a wound. At that time, we may have to give an additional dose of analgesic before starting a dressing. And sometimes we may have to give a xylocaine application, lignocaine application over the wound, and then we have to dress it. And next one, please. Next slide. Okay. So these are things that you are expecting when you're dressing. Next slide, please. So how do we control the stench? How do we control the stench now? It is going to be very stinky, right? So how many of us can actually bear a stench apart from wearing a mask? Fine. So we should make sure daily cleansing and frequent dressing change is done. Initially, it will be very difficult. But as you change the dressing very frequently, in a couple of days, you will find that stench reducing. And then local application of metronidazole. What we do is we sometimes actually have to crush metronidazole tablets and apply over the wound. This actually helps, and it is cost effective also. IV metronidazole irrigation can be done, but it is a little more expensive. As I told you, resource allocation, it actually changes when it comes to hospice care, because it is a long time. And what is the end result? Patient is walking out. No. So we must make sure resources are properly distributed. So we must find means by which, with little expense, best care is provided. And ginger grass oil, actually, I think it is brought from Kerala. So this smells beautiful. What you have to do is take a little bit of it in a cotton ball and sponge it around the wound. After the dressing, just dab it around the wound on the normal skin. It actually removes the stench. Next one, please. Infection control is very important. Systemic antibiotics may be required. Next one, please. So bleeding, as I told you, it is very, very painful for the patient as well as those who are seeing it. So we have to actually, when you know there is a major blood vessel that can be corroded and that may cause a major bleed, you must always teach them what to do and what to expect. And the bed sheets and the dressing material, it should be of a darker color. If you're using white bed sheet, it becomes very dramatic with so much of blood loss. So make use of darker color sheets. And adrenaline packs can be used for stopping the bleed immediately. It causes vasoconstriction. But what happens is there'll be a rebound effect. Then as the adrenaline effect reduces, there's massive bleeding suddenly. Right? So sometimes we may have to go for a palliative radiotherapy or surgically cauterize the blood vessel to stop the bleed. Next slide, please. So anticipation of the bleeding is very important, and making sure they are prepared to face it, because most often it may happen at home. At that time, patients' family may faint. They may feel, and all their life they will remember the blood spill. So be careful about it. And sometimes we may have to sedate the patient because, after a carotid blast, what are we expecting to do? Are we going to transfuse blood? How are we going to stop the carotid bleeding? Right? So we may have to sedate the patient. Next slide, please. Maggots. So maggots are something that can be obnoxious to the patient and for the healthcare workers. How do we remove it? Initially, thousands will be there. We have to dip a cotton ball in turpentine or ether and place it outside the wound. For the smell of the ether or turpentine, what happens is the maggots start crawling out. At that time, manually using a forceps, you have to remove each of the maggots and put it into kerosene. Okay, so that way it may require several sittings for removing all the maggots. Then only we can go for proper wound care after that. Next slide, please. Next slide, please. Pressure ulcers may be really deep. You will always find grade 4 pressure ulcers when they are being brought to the hospice care. They are no more able to take care of patients. That is the level they bring them. So these pressure ulcer care is actually, all of us have seen patients. So the regular bed cradle, pillows, water beds, egg grates, these can actually help in a very big way. Positioning, next slide, please. Next slide, please. Positioning is very essential. They say a rule of 30, where none of the pressure points will, it actually puts the body in 30 degrees in every angle. So they say that all the pressure points are relieved in it. You'll have to browse through it. It's a nice one. Next slide, please. So this is every 2 hours how you position it with a chart. Next slide, please. So water beds are common because we're thinking about a cost-effective manner. So alpha beds may not be provided. So we should think of as a way by which we can use water beds and air mattresses to reduce the pressure. Next slide, please. So moisturizing the skin is very essential because dry skin usually results in pressure ulcers. Next slide, please. Okay. So oral cancers, oral care is very important. As I told you, lemon juice is a very beautiful option. Half a lemon in half a tumbler of water, and this can be used for a mouthwash instead of chlorhexidine. Of course, chlorhexidine is really good, but to make the mouth feel fresh, this mouthwash can be used on a regular basis, and it is cost effective, and patients and family also can easily do it for themselves. And never have a dry mouth. Liquid paraffin is preferred over glycerin because glycerin has the sweetness in it, and that can be, attract a lot of insects. And adrenaline pack can be used in case of bleeding. As I told you, it may cause rebound bleeding also. Fungating wounds, we have to use metronidazole, rinse, mouthwash for them. And you can use 500 milligram or 1000 milligram of metronidazole crushed, and you put in 1000 ml of boiled cooled water. That is good enough for a rinse. Next slide, please. Douche is also the same way. You can give a metronidazole rinse. If you're having a fluid, that is really good. But when our pockets are not comfortable enough, 1000 milligram of metronidazole tablet crushed and used mixed with 1000 ml of boiled cooled water. That is good enough for a douche. Next slide, please. Lymphedema. It is another common ailment, and there we have so many cases of breast cancer. So lymphedema is very common. Next slide, please. So here again, we have to concentrate on these 4 aspects when we are thinking about lymphedema. Next slide, please. So skincare, you must make sure it is the skin is thoroughly washed. Use a soft towel and dab it, not rub it. Okay. Then cotton socks, and make sure the area is dry and cool. Apply antifungal cream. Fine. Protect the skin. Advise them to wear gloves when they have to use any gardening or any other, any other things, because they shouldn't get injured in the lymphedema hand. And you should always watch for signs and symptoms of infection. Next slide, please. So general principles of we must make sure they're able to do gentle, regular exercises as much as they can. Encourage them with normal activities, even taking a spoon and eating. That is big achievement for them. Okay, Max, encourage every small bit of normal activity in them. Next slide. So simple lymphatic massage. So remember, we are not like a masseur. You shouldn't press on the muscles. It should be on the superficial layer. Just over the skin, gentle circular massaging towards the heart. That actually drains the lymphatics towards the heart, and that reduces the lymphedema. And you'll have to use some. Make sure the hands are nice, warm, and dry, and it should not cause friction on the superficial skin. Next slide, please. Start always from the non-congested area and towards the heart, and then very minimal pressure. Very minimal pressure. If you shouldn't concentrate on the muscles, it must be on the skin, because you are concentrating on the lymphatics. And then do not, especially when there is edema, don't massage over the edema. Around the edema is what you have to massage. Next slide, please. So these are usual compression garments that we may use for reducing the lymphedema. Next slide, please. So when we are doing a dressing for lymphedema, a bandaging, you will have to always start from distal and go towards the proximal aspect, not from proximal to distal, from distal to proximal. So from the fingers, then the wrist, then the elbow, then upper arm. And always put one layer of soft cotton inside so that it doesn't cause itching. Next slide, please. Next slide, please. Ostomies. These are another common factor with any, this is also a palliative part. So when you're thinking about ostomies, we have colostomies and ileostomies. So you must know how to assess the stoma. Next slide, please. Which is a good stoma, which is a bad stoma, and then according to that, then you must know when to change the stoma bag, and what is the location, what kind of fecal matter is going to come out of it, and how often are we going to change the bag? Is it a temporary one or a permanent? Most often it is permanent when it comes to palliative care. And how are we going to help them with reusable bags? All this we must have good knowledge of when we are teaching them. Next slide, please. So you must have an idea of what can be taught, how they should measure, and how they have to do it. Next slide, please. So ileostomy is something that you must understand is different from colostomy. How do we differentiate is the content. So when patients are having an ileostomy, the content is not formed stools. There's a lot of gastric juices that are coming out that usually hurts the skin around the stoma. So when it is ileostomy, skin care around the stoma is very, very important. And the next thing is there is vitamin B12 deficiency that is common when we are talking about a ileostomy patient. So B12 supplementation is essential for them. So have it on mind when you're taking care of a patient with ileostomy, skin care and B12 deficiency. Next slide, please. So make sure there is no odor. Carrying the bag, they call it the shit bag. Okay, they're carrying the shit bag may be very, very embarrassing for them. And when it starts smelling, it is even more embarrassing. In the starting part, people with colostomy, they never even leave their houses. They confine themselves, not even within the house, they walk around. They confine themselves within the house. So reducing the stench is very important. There are several products that are available to reduce the stench. And then you must teach them how to remove the bag and change it. And when there may be a lot of hair around the ostoma, you must teach them how to cleanse the hair, how to remove the hair, how frequent shaving may be required in the direction of hair growth, so that there is no infection at the hair, at the root of the hair. So all this should be taught to them. And when they're wiping, mild dabbing and wiping is essential. If you're using tissue paper, that paper will be sticking around. So moist tissue paper is always good to clean. Next slide, please. Wet cloth is preferable. Next slide, please. Yeah. So communication, I think Dr. Devas has already had, but most of us do not have the guts to communicate. A friend was admitted and her husband was admitted. And he was in the ICU and she was in the ward. And every day I used to communicate with her on how her husband is doing and what treatment is being taken care and how it is, because it was a situation where they couldn't meet each other. And she was relying on me, talking to the caregivers and so. And suddenly the husband started deteriorating. And it was a time where the chest CT thorax was done and it was not very promising. And I know what is happening. The doctors have actually explained to me what exactly is happening to the patient. You won't believe it. For 3 days, I did not pick up her call. I did not talk to her. And finally, the doctors had actually been talking to her, apart from me, counseling her every day. And they had asked, they had permitted her to come and see the patient. I was able to talk to her only after her patient's death. Because I really was, even after her patient's death, I had to muster so much of energy in myself to talk to my friend. It was very, very painful. Okay, so being honest, having the guts to speak to the patient and breaking the bad news, all this requires a lot of inner strength in ourselves. We cannot do it easily because it's not something that can be done as a routine, as a job. That requires a lot of empathy. Next slide, please. Ethics. We really have to know. Patient likes to eat something. He's not supposed to eat or drink. But we know this is the time where this is the last wish that can be given. So it is okay. We may have to be flexible at times, but not at compromising the health. You must know how to weigh what is right and what is wrong. Sedation, when to sedate, how much, what kind of condition they are in. Next, CPR. Is it really essential? At a time, because as nurses, we immediately jump and go for reviving the patient. After all the ribs broken, what is the use? The patient may live for a day with all the trachea torn with intubation and another 1 lakh added to the bill. What have we done? Carers, how are they going to take the death? How are they going to take the prognosis? Euthanasia, is it okay? Is it okay to reduce the suffering? Next slide, please. Above all, remember, we really have to support each other if we really have to step into palliative care and take care of them. Next slide, please. Thank you. If you have any questions, you may ask. I think I overshot the time. Thank you so much.
Thank you so much, Ms. Selma. Thomas, for highlighting us about the nurse's role, which is very, very important and the main highlight of this today's topic. And I think you have covered all the aspects, even though the time you have exceeded the time. and we cannot forego without telling all these points, which is very, very important. And really, I appreciate you in spite of your busy schedule during your duty time. And on behalf of my request, you pull out your mask, and then don't blame me in future if you get into trouble. And then
As long
thank
as I don't end up paying the fine for it.
okay. Thank you so much for highlighting and giving us in detail about the nurse's role on palliative care, which is very, very important. I hope all the participants would have been benefited. Now I request the participants to put, if there is any question in the questions or doubts or queries, to put it in the chat box. So quickly we can finish it up. Selma, madam, just give me a couple of minutes so I can just go through scroll through if there is any. If there is no questions, we understood that all the speakers have thoroughly spoken about the topic given to them. With this, I think I will conclude. If there is no questions, there is a lot of appreciations and applause from all the participants. And before I could conclude, once again, I request the participants, the feedback form has been sent in the chat box so that you can fill the feedback form and send it back to us, revert back to us so that you will get an e-certificate. So with this, I would like to conclude. I'm happy and thoroughly satisfied with this power-packed information given by all the three roses, which I thoroughly enjoyed with the taste, color, and the flavor of this today's webinar on substratum of palliative care. And I'm sorry, like I think Madam Devakribai have left, and Madam Angel David is here with us. Madam, once again, I take this opportunity in thanking all the three speakers and resource person who have really spent your valuable time. And I'm very happy that I'm very happy to say that all the three of were my best friends and very good personalities in my life. And they are the trainers in the palliative care too. And they did their best, and I hope we have done, and I also personally feel that I did justice in putting this topic as today's webinar, and all my friends have did their best to do. And all the participants, madam, I personally, on behalf of all the participants, to all the resource speakers, I say that definitely we all have been nourished and received your knowledge and share what you have shared with us. Thank you once again. And also I take this opportunity in thanking the principals from other colleges, professors, teachers. I could see there were many staff nurses and nursing officers who participated from all over India, and I should have made it as a national webinar. All over India, from other parts of India also they have participated. I'm really proud to see that the topic has reached people, and the students and the teachers and my dear colleagues who have participated in this for this seminar, for this webinar. Thank you once again. And also I take this opportunity in thanking the admission team, Ms. Deepa and Mr. Ali, and my special regards and thanks to Mr. Imtiaz for the technical support, who have been throughout all the webinars. I keep mentioning, without whom we would have not be able to run this show without any flaws. Thank you so much, Mr. Imtiaz, for being with us throughout the webinars. And once again, I take this opportunity thanking one and all for joining us on today's virtual meet. Thank you all. And I think shortly we may come up with the next webinar. Until then, signing off, and bye-bye to all of you by Dr. Sharmila. And have a good day. Stay safe. Thank you all. Bye.
அப்ப சொன்னாங்க. அதனால நல்லா இருந்துச்சு. தேர்ட் செஷன்ல ஃபுல்லா வந்திருப்பாங்க அட்லீஸ்ட். நிறைய ஸ்லைட் எனக்கு பாக்குறேன். இன்னும் ஃபாஸ்டா முடிஞ்சிருக்கும். ஆமா. நெக்ஸ்ட் ஸ்லைட் சொல்றதுக்கே நடுவுல டைம் போகுது. If I'm moving the slide na I'm faster டக்கு போயிட்டே இருக்கேன். நம்ம மூவ் பண்ணும்போது sometimes அது ஸ்டக் ஆயிடுது மேம். அதனால நம்ம வந்து ஹோஸ்ட் பண்றோம். லாஸ்ட் டைம் எனக்கு வந்து ஃபெசிலிட்டி இல்ல ஸ்லைட் ஷேரிங். அதனால சரி இருங்க நம்ம என்னன்னா தமிழா ரெடி பண்ணனும். அதான் ஏன்னா நான் லாஸ்ட் டைம் வந்து எம்எஸ் ஆபீஸ்ல வாங்கிட்டு போயிட்டேன்.
Yes, da. Thank you, da.
நன்றாக இருந்தது. நீங்க இருந்தீங்க அப்போ?
இவதான் எனக்கு டெக்னிக்கல் சப்போர்ட். இப்பதான் கஷ்டப்பட்டு மாஸ்க் தர
நீங்க ஐஸ் கியூப் சொல்லியிருக்காங்க, இதுல சொல்லியிருக்காங்க. லெமன் அதான் சொல்லியிருக்காங்க. சூப்பரா சொன்னீங்க. அது கொஞ்சம் நல்லா இருந்துச்சு. எங்காலும் தாத்தா இந்த நம்பர் அனுப்பி விட்டேன் போடு. கொஞ்சம் தண்ணி கொடுக்காம ஆரம்பிச்சு முடிச்சிட்டாங்க.
இன்னும் ஒரு முடித்து விட்டோம். பார்க்கவே புருஷன் வேற சா வச்சிருங்க. என்ன பேசிட்டு இருந்த? எல்லாரும் டாட்டா சொல்றத விட்டுட்டு
Hello.